Thank you. Good afternoon. At the outset, I thank Dr. Jiang, the whole organizing committee of VSRNM for kind invitation. So next 20 minutes, we have heard that the excellent lecture by the two previous speaker. We have seen that the trauma and degenerative diseases. So let's see like how the infections looks like on imaging. So I'll put it in one by one. So this is will be the outline starting from pathogenesis to pyogenic and this tuberculosis. So we all know that the spinal infections is comprising around 2 to 7% of the infections, MSK infections. There is actually the spectrum of disease. We start from starting from the discitis to osteomyelitis and the prevertebral and epidural lesions. Why the important? The issue that why the imaging is important. So imaging is important not only for the diagnosis, but for the treatment planning as well as for the follow-up cases. That's why the imaging play very, very important role. And as a radiologist, we must understand what are the normal features, the features of particular infections, how to report it, what to report it, and what are the clinicians needed from you. So just to understand the pathogenesis of the spinal infections, and it can be the mode of the infections can be the more commonly is the hematogenous, that can be the contiguous spread or maybe a direct inoculation. The important thing to understand why the infections occur usually at the disc level. That's important to understand. So usually the infection in hematogen infection, because of the rich vascular supply, they get entrapped, the bacteria entrapped here, and they causes the end plate infections, and then it causes the infections of the adjacent the vertebrae as well as in the disc. So that's the pathogenesis, and most of the cases you will see that most of the cases the infection start from here and then it can progress later on. So what is the imaging modality nowadays? We are having the most of the centers that we have a radiograph which is like available since many years. Then we have a radioisotope imaging, then computer CT scan, then the MRIs are available, and we'll just see that what are the advantage and disadvantage of particular the imaging modality. We know that the radiograph is available all the times, but why it has because it has a less sensitivity and the specificity. The other important point is that it's actually the findings appear slightly late and up to 2 to 8 weeks. So we don't want that. We want to diagnose the infections as early as possible to get the to get a proper treatment. So that's why the radiograph usually is not the first line modality in the early infections. But if cases of later stages, you can see that some changes can be there in the end plates, and then can be distractions are there. But we want, that's why the MRI is important. The MRI is important because it depicts the changes as early as possible. Why the CT scan? What is the role of CT scan? It's evaluate better than the radiograph, but lacks specificity. If bone destruction is there, then it can evaluate what kind of bone destruction is there. The pre-vertebral collection, which is large, then you can identify it. The most important, the role of the CT scan is to guide for the diagnosis and the therapeutic. So you want to do the biopsy, you want to aspirate the collection, then you can do the guidance. So CT guidance, you can do these procedures. So then comes the MRI, and we all know that the MRI is the gold standard for all the infections. Why? Because we have all the features which we all know because of the multiplanar capability, and it not only evaluate the bones, but in fact it evaluate everything apart from the bones also, like the spinal cord, the other area, all the structures of the spinal cord, they can be evaluated. So neuronal component, if the infection causes any changes in the neural compromise, then can also be evaluated by MRI. So why is the modality of choice? because of these statics. So it's a highly sensitive, you can see, so up to 96 and accuracy of 94% is described. So it's very, very highly sensitive and specific, and it can actively, it can differentiate whether the infection is active or it is resolving. That is also possible. And we'll see some of the sign where the MRI is more of diagnostic. What is the role of radioisotope or nuclear medicines? Obviously the WBC tagged indium, SPECT images with the gallium-67, they are more useful for the infections nowadays because of the availability of the PET-CT scan, and it can provide so much of sensitivity. You can see here that up to 95 to 97% of the sensitivity it can provide. So it's actually, whenever is available in some of the hospital, people are not afraid to use it, using it. So the MR as well as the PET scan, they have a very, very important role in the infections, and then you can use depend upon the indications, disadvantage, availability, you can use it. So what are the type of infections? We all know the type infection can be of the pyogenic group or the non-pyogenic group. The non-pyogenic group, the commonly like in the Asian country, the tuberculosis is quite common. Then we can have the whole list is there. The infection, the fungal infection can involve, the viral infection can be there. There's a lot of protozoal infection can be there. I will show you some of the examples of each of these infections, and then so to know about it, how they appear on imaging. So most common is the pyogenic spondylitis or pyogenic infections. So what, as I said, that what the infections usually causes is the starting from the infection. So they can be a hypointensity and hyperintensity on T2 imaging. The changes in the disc is very, very important. So you see there is the irregularity in the disc, as well as it's causing the hyperintensity, as well as the change in the contour of the intervertebral disc. So that is the one of the, this is, as I said, in the pathogenesis also, if you see these changes in the end plates, you see in the disc and changes in the vertebrae, then the infections were quite common. And then if it has the prevertebral and paravertebral collection, then the possibility is more likely. When the infections got delayed or treatment is not adequate, then it can lead to the more vertebral destruction. They can be collapse of the vertebrae, and they can causes the neural compromise. Here you can see that you can cause compromise to the neural foramina. So this can be there if the infections is detected in later stages, and so the role of the radiologist to detect the changes as early possible, so patient get benefited by the imaging, and then your role is very, very important in that way. So what is actually this is the sign which is described in the literature, that's called the Shaw sign. What is there normally, like we have the Shaws on the either side of the vertebra, particularly in the lumbar region, and then we have a very well-defined fat planes. But in cases of the infections, like whether it's a pyogenic or maybe the tuberculosis, particularly the active infections, it shows the blurring of the margin. If you can see something here, the blurring of margin is there, and there is a signal intensity, change in signal intensity, minimal fluid, or they may be of the inflammatory changes are there, which causes the blurring of the margin of the psoas muscles. That is nothing else, it's just a Shaw sign. And this is a wonderful sign you can use in your clinical practice to differentiate whether it is an infection versus the degenerative disc disease, because in many times it can mimic the infection as well as the degenerative disease. So this is one of the important signs which you can use. The epidural infection can be in the isolated form or can be associated with the discitis, and you can see that the collection can be seen in the anterior and posterior aspect. It can compress the thecal sac as well as the spinal cord, and nothing is a simple kind of fluid where it's appear as a T2 hyperintense and T1 hyperintense, as well as it shows the infection, it shows the enhancement, so peripheral enhancement, and the central hypointensity is suggestive of the inflammatory collections in the spinal cord. Sometimes the facet joint can also involved by the infection, sometimes in isolated way, sometimes associated with the spondylodiscitis. So what happens normally, we know that the facet joint is a true synovial joint. So this, any kind of the changes, it can occur like in the synovial joint, like the joint space widening, articular distraction, the fusion, whatever like we see in the other synovial joint. All the features can be there. In later stage, they can be associated with the paraspinal soft tissue component, and they can involve the other structures also. So see here, this is another side, the normal facet joint here, but what is happening here, there is a destruction of the facet joint associated with the soft tissue, the inflammation, and which is extending posteriorly also. So these are the things that you must understand, and you must report that the unilateral facet joint is involved. So unilaterality is another important point. That whenever there is one joint is involved, then the infection should be ruled out. Wherever is there, whether it's a knee joint or any other joint, or the facet joint, unilateral involvement can be a suggestive of the septic arthritis. Brucellosis again is a kind of disease process where it sometimes is very difficult to differentiate with the pyogenic or the infection like the staphylococcus or streptococcus. But some of the features which is described in this way, that sometimes the changes may be minimal, and obviously the lot of changes can be there in the vertebrae. Sometime in CT scan you can see the bone sclerosis, because a lot of the bone sclerosis can be there. But obviously you just understand that this can mimic the pyogenic infection, but obviously if you know the history as well as the features or the clinical features, the lab parameters, you can differentiate with this. We know about the tuberculosis. We know that tuberculosis is very, very common in the Asian country, particularly in the endemic regions. And again, the pathogenesis is nearly similar, where it's causes the spondylodiscitis as well as the collection in pre and paravertebral locations. And so what is the type of this TB? It can be in a 4 type actually. So I'll show you example of each case. So one is the paradiscal, anterior, central, and neural arch. So I'll show you one of the imaging features, how they appears on MRI. And we all know that the thoracolumbar junction is quite common for the involvement. So see, this one is the case of paradiscal, the pattern here. Again, you can see there is a disc, predominantly the infections confined to the disc region and paradiscal region. So where the end plate changes, destruction of end plate can be there, and which you can see on the radiograph as well as on the CT scan as well as on MRI. In cases, so sometimes the patients have a problem, but on MRI you can't see anything. Those patients, we must see that in follow-up cases, that sometimes the changes in the MR can found in later stages. Here, like the patient, the initial patient in January, the thing like the MRI looks like normal, but after the 3 months, or you can say that you can see the changes in the 2 places, and it's typical of the spondylodiscitis also. So again, the dictum is here that patients have a very typical features, and on MRI, we all know that MRI is very, very sensitive, but you can't find the changes. So you must not stop there. You can follow these cases, and you can find these changes on MRI also. What is the anterior pattern? So anterior pattern actually is the involvement of the anterior vertebral body. Here you can see the vertebral bodies are involved predominantly in the anterior aspect, associated with the large and the soft tissue component, which goes around the subligamentous locations here. So this is kind of multiple level, and this collection is extending from superior to inferior location. So this is the key kind of cases where the tuberculosis is quite common, which extend along the subligamentous region. Another important features to differentiate is the kind of the calcification in the infections, and you can see the abscess formation or the inflammatory tissue, which shows the calcification. The chances is that this is the most likely of tuberculosis. Sometimes in cases of the central pattern, the lesion is confined to the vertebrae, not involving the paradiscal location. So paradiscal is more common, but sometimes you can find this lesion isolatedly involving the vertebral body, and cases like here, like again the posterior elements also can be involved, and here isolated also. But these are quite rare. So commonest is the more of paradiscal location and subligamentous or anterior location. Sometimes you can see the multicentric lesions here. Sometimes only the vertebrae are involved. And in those cases, it's quite difficult to differentiate with the other pathology like sarcoidosis or multiple myeloma or metastasis also. So these are the very difficult situations, and you have to give the differential diagnosis to clinicians. And these patients require the biopsy to say actually it's a tuberculosis. So these are some of the features to differentiate this one, the TB and the pyogenic group. But we have already described that the abscess wall is thick and irregular. Thin and the smooth wall is usually in the tuberculosis. As I said, the disc destruction is more early in the pyogenic group, and it is more late in the tuberculosis. The calcification, as I said, if you find the calcifications in the infiltrated tissue, is more likely of tuberculosis. So you can remember 2 or 3 points to differentiate. Obviously, all these features may not be available in all the examination, but if you find these changes, then you can say that probably we are dealing with the tuberculosis. Fungal infection, again, it can involve the similar kind of way, like in pyogenic infections. And again, sometimes it's difficult to differentiate until you have the features like the large kind of collections or the fungal infection, chest cavity within that, the fungal ball is there in the chest cavity. So this is some kind of case, the case of the fungal infection. You can see there is a large cavity within the chest. So usually the chest cavity with the fungal ball, if they have involvement of the vertebrae, then you think that probably the infection is because of the fungal infection. Again, there are some features which are relative actually. It's not like short, but if we see that the posterior element involvement, the disc involvement, and the lesion, the spinal soft tissue is more larger in tuberculosis in comparison to the fungal lesion. Coming to some of the rare cases kind of thing which you may see in your lifetime, or you may not be able to see it, kind of like we can see the hydrated. In my clinical practice in 20 years, I have just seen 3 cases. So it's not very common, but if you see, because it has a very typical imaging features, and so if you find it out, then you can easily appreciate. Usually the spine, the 50% are found in the sacrum, and usually shows the multilocular cystic lesions here kind of thing. So see here, there is a multilobulated, multicystic lesion which is T2 hyperintense and T1 hyperintense. So similar kind of like hydatitis anywhere in the body, they appear as a T2 hypointense and T2 hyperintense, and they usually lack the contrast enhancement. So these 3 points you should remember: the T1 hypointensity, T2 hyperintensity, multiloculated lesions, and the lack of enhancement. If these features are there, then probably you are dealing with some hydrated cyst. So again, this is the axial image of the same patient, and typical, like this is kind of you can see the similar kind of features in the liver cyst or any other the hydrated cyst. So similarly, the imaging features are nearly similar. Cysticercosis, again, usually the vertebrae are not involved. Usually they involve the spinal cord here. So again, see, usually the cysticercosis, usually a very small cystic lesions can be seen in the spinal cord. This shows typical peripheral enhancement. Here you can see and the central cystic region. So typically, again, it can be seen in the muscles. It can be seen in the spinal cord again, and these are nearly quite diagnostic. If you can see the scolex within that the cysticercus. As I said, the previous speaker, as I said, that sometimes it can be difficult to differentiate the degenerative disc disease and the infection. And our day-to-day practice, clinically, I can say that this is, again, is a very dilemma. You always feel a dilemma whether you are dealing with the infections or the degenerative disease. So there are some points are there which can suggest probably that we are dealing with the infection, and if you are not dealing with the disc disease. So usually in the case of disc disease, if you can see this edema in the vertebrae or end plate, but usually the disc is usually hypointense. So it's a desiccated. So not much of the fluid is there in the disc. So the infection is not there. So probably in these cases, probably you are dealing with the degenerative disc disease, not the infection. Just the last case here, again, the people have described this as a claw sign. in the literature to differentiate degenerative disc disease versus infection. And what they have said that usually you can see the diffusion disc here, usually the hyperintensity in the anterior and the end plate just above the end plate in the vertebrae, and that's make it a kind of claw here. So that's if you see, so this is again a feature of the degenerative disc disease because the disc is not involved. So if the disc is involved here, then it will not make it a claw sign. So again, if you see this one, then it again suggests of the degenerative disc disease. So just to finalize, the things, I was just to highlight or just to want to say something that in spinal infection is not uncommon, particularly in the developing countries. Imaging is very, very important. We have seen the role of radiograph. We have seen the role of the CT scan. We have seen the MRI. We all know that the MRI is the gold standard because it shows everything related with the bone, the disc, as well as the other structures. So MRI is the gold standard. Radiologists must understand the typical feature, how they appear, like the pyogenic group, the infection, the other infection. They can, obviously I can say that on 100% cases, you may not be able to differentiate. But obviously in this definitely in significant number of cases, MRI can be helpful to tell what is the diagnosis. And not only the diagnosis, but it can take you that where the treatment plan, and you can follow these cases. So treatment as well as the treatment plan, diagnosis, treatment plan, and follow-up. All three things can be done by on imaging. Always keep in the mimicus in the mind, particular degenerative disease. And many times we have seen, still there is a confusion, and still you can't diagnose the aspiration and biopsy is the ultimate answer. With that, I thank you for your kind patience for listening. Thank you very much.